Hello, everyone. Welcome to Healing by Design, the podcast where we amplify the voices that matter most in wound care. I'm Jen Bierhup, and I am here with my co-host, Therese Laub. We are so glad you found us, and we can't wait to dig into today's conversation. Before we jump in, I do want to take just a quick moment to cover a few things. Everything we talk about on this podcast is meant to educate and inform. It's not medical advice, and it shouldn't be taken as a diagnosis or treatment recommendations. Your situation is unique, and your healthcare provider is always your best resource for decisions about your care. The opinions our guests share are their own. They don't speak for PAWSIC or our sponsors. And if any of our guests have professional or financial ties to products or companies we discuss, we'll always be upfront about that. One more thing. If you're ever dealing with a wound care emergency, please don't look to us for that. Go to a provider right away. Now that we have all of the disclaimers out of the way, let's dive right into our show. Hello, and welcome to our next installment of Healing by Design, the PAWSIC podcast. I am ridiculously excited today. I have a guest on that I am been waiting to interview for a very, very long time since I first met him. His name is Isaac Zralii. And Isaac is the very first certified nursing assistant to join the Post-Acute Skin and Wound Integrity Council Board of Directors. And it is phenomenal to have him on the Board of Directors. He brings over 21 years of hands-on clinical experience and is a fierce advocate for systemic change within the healthcare industry. Isaac is an alumni of the Liberty University and Old Dominion University, both of Virginia. He has extensive media presence regarding CNA equity issues, LGBTQ, health advocacy, and mental health issues as well. When he is not tackling tough conversations, he enjoys watching cooking shows with his fiancée and his 3 cats. So Isaac, welcome to Healing by Design.
Thank you for having me.
So first off, I want to get to know you a little bit better. So tell us a little bit about yourself, and then tell us a little bit about your journey to becoming a CNA. You kind of made a comment about being maybe a reluctant CNA. So give us a little bit about that background.
I am definitely the reluctant CNA, and I don't think that I'm any different from any part of my community that says we are all kind of reluctant CNAs in some aspect. So I got my CNA license initially in 2005. So I've been at this 21 years, off and on. I have made sporadic breaks to try different industries. But somehow scrub life keeps pulling me back into the fold. As much as I want to run away from it, I can't. And it's really been a fantastic journey. I never thought as a young 18-year-old with my CNA license leaving high school that I would say that I am now 40 years old and a CNA and very proud of what I do. So that was definitely a turning point, because if I looked at my younger self, I'd be like, wait a minute. But the last about 7 years of my CNA experience has been doing short-term contract work. So that has taken me literally around the country and sailing in the Caribbean. So that was really, really fantastic. So I worked all throughout the pandemic. I was in 5 different states in 2020, helping with COVID relief, and have worked in inpatient behavioral health, acute care hospitals, med-surg, long-term care, skilled nursing rehab, mental health support detox centers. So it's really been a fantastic journey.
Wow. So if I'm hearing correctly, you have a huge amount of experience as a CNA in multiple settings. So not only post-acute, multiple different types of post-acute, but also acute as well. So
correct.
That is an extensive career. So I cannot wait to get some of your feedback on some of these questions then, because you're going to bring that from all different settings, all of that experience. So tell me a little bit about Liberty University and Old Dominion University. Tell me. Liberty.
Wow. Yeah. If you're not familiar with Liberty University, they are known as the world's largest evangelical Christian university. They are centered in Lynchburg, Lynchburg, Virginia. It was founded by Jerry Falwell in 1972, and it is very Southern Baptist forward. So that was a different kind of experience for me because I come from a very complex background. But I do have an associate's degree through them. I was working on my bachelor's degree and took a kind of a left turn pivot and ended up finishing that at Old Dominion.
Wow. Okay.
Yep.
So I'm curious, what is your bachelor's degree in? We don't have to. I'm curious.
So I do have a bachelor's of science in psychology. I was working on a minor in nonprofit or public service and didn't quite
wow.
finish that minor, but do have the bachelor's of science. Yeah.
That is fantastic. Wonderful. Well, and that kind of explains, again, I have the great pleasure of being on the board of directors with Isaac over at PAWSIC, and you really do bring such a fantastic perspective about people and personalities and how people should communicate. And so that makes absolutely perfect sense to me that you have your bachelor's in psychology. I totally see that for sure.
Yeah.
Oh, so tell me a little bit. So if we talk about wound care and CNA, tell me a little bit about what we talked about this earlier. What got you into PAWSIC? Like what was your draw? Because I think that's important for everybody to hear.
So I consider myself a lifetime learner. It's something that I am very proud of. I'm always listening to audiobooks, podcasts, kind of what's going on in the media. My realm on politics, not so much, but as far as like what's going on as in the industry and within healthcare, I try to stay on top of things. And I'm very active on LinkedIn, and LinkedIn was advertising a WoundCon conference, which is specific to advanced practice providers and wound prevention and management. And I was like, well, I'm sitting at home. I can log in and catch the seminars and see if anything is pertinent to CNAs. And a lot of the information is, but not framed in a way that makes sense. So PAWSIC did have a presentation, and I followed along to it, and they were talking about how we are all part of a holistic care team. And they mentioned advanced practice providers like nurse practitioners, DOs, and then the classic dietitians, occupational therapists. And then there was this gap, and I was like, so is that gap where the CNAs belong, or is that kind of like a placeholder? Because I understand that, as a holistic team, there is always room for more people at the table and more perspectives. So I got in touch with PAWSIC and I said, hey, so let's kind of continue this conversation of what I saw in your presentation. And it created this fantastic dialogue about where CNAs are not always at the table to have the discussions. And I constantly say the same statement, which is CNAs do not have the vocabulary to have the conversations. And that's where...
And what do you mean? Yeah, explain that to me a little bit. Like, I mean, just so I can understand that a little bit better.
So in the acute care setting, I was working on a med-surg floor, and we had one of the product providers come in and give us training on how to use the creams and the barrier creams. And that was super informative, but that was a very specific product for an acute care setting for specific med-surg issues. The products that are out on the market in long-term care, we don't get a lot of proper training for. They are just like, here's this cream, use it. So when we're not seeing improvements in some of the wound issues, or we're not seeing any change, then we don't have the vocabulary to tell our nurse, we're using this cream, we're using it every day, we're using it, as prescribed, but it's not doing anything. And the wound on Miss Jones's backside is getting worse, but we can't say what it looks like because we don't have that vocabulary, and we can't say, it has now exceeded the parameters, or it's now, 3 inches or whatnot, because wound prevention, education, and management is not part of CNA curriculum.
And I think that, one of our questions is what does the wound care industry need to understand about CNAs? And I think you just said that, is that vernacular, if you will, is not extended. That education is not extended at all to CNAs. I mean, almost completely blocked out, if you will.
Correct.
We almost lock that whole CNA group just gets completely locked out of any of that true education. And I think, if I'm not mistaken, Isaac, if it was done in the correct fashion, wow, what a difference that would make. if we brought that education to the CNAs.
Now,
Wow.
one of the issues that we have as CNAs is there's not a national expectation of what a CNA class is. For a nursing board, generally it's, accepted that there's a 2-year associates and a 4-year bachelor's, and then you have, you build on that. CNAs across the nation have a variety of different training programs. In Florida, you can get certified with enough requirements to take state licensure in 3 days.
Wow.
Yeah.
I don't think I realized it was that short. I always
3
thought
days.
maybe in Ohio. I'm in Ohio, so I feel like it's different here, but it maybe it's not. I don't know.
Right. So in Florida, you can literally have all of the requirements necessary to take the state licensure exam in 3 days. In Virginia, the CNA training program that's part of our school district is a 2-year program. So see the vast difference between 3 days and 2 years.
Oh my gosh! Wow. Oh wow! Is that for like the certified? So like you would be certified then after that, like the certified nurse assistant type of thing.
You have for Virginia for the 2-year
STNA.
program. Well, you're right. Ohio has the STNA. For Virginia, it's the CNA, and in those 2 years, they have met the criteria for the licensing for state of Virginia to be able to take the licensing exam. Yep.
Wow.
Yeah.
So what a difference. I want to take a moment to tell you about something I'm really proud of, and that is Libellen Learning. For years, wound care case management has existed in this space where clinical expertise meets care coordination, and yet there has never been a dedicated educational home for the professionals doing this work every day. Nobody was building for the wound care case manager specifically, so we did. Libellen Learning was founded to fill that gap. We are pioneers in developing education designed specifically for wound care case managers, the nurses, the coordinators, the clinicians navigating complex patients across every care setting, the ones who are often doing everything right, but without the resources and recognition they deserve. We believe that when wound care case managers are educated, supported, and empowered, patients heal, systems work better, and the outcomes, they speak for themselves. If that sounds like the work you're doing, or the work you want to be doing, Libellen Learning was built for you. Find us on LinkedIn and come grow with us. Wow. Oh my gosh. That is amazing. But I know that because I did actually get asked to teach some CNAs, some skin and wound care. And what I found most intriguing about it was that they were hungry for that information. They were so excited. There were so many questions. There was millions of questions, and these questions were incredibly good, and they were necessary. And what hit me is that, oh my gosh, we have an entire army of people, of professionals that are with the patients at the most important times, as in feeding, as in getting bathed, as in changing beds, as in helping them to and from, as in being there for them as a person. And we don't empower our CNAs with the information that they need in order to, move information back and forth between, RNs, LPNs, things like that. Like what you said, it's mind-blowing to me. I'm overwhelmed at the fact that we have, as a profession, left you out. And that's, it's terrible. Absolutely terrible. So there was something that you had said.
Well, go ahead. Your observations is that, we do want the information. We do want to learn. And that kind of goes against the grain of some of the sentiments that we hear from nurses about, CNAs aren't interested. They're disengaged. They don't want to learn. They're just here for a paycheck. So that you can see what the reality is on your side, and I can tell you what the reality is on my side, and what the sentiment is coming from the other side.
Now, you said to me that you are on a lot of forums, so you do a lot of communication with other CNAs, and obviously you've done this across the country. So I think what makes you so important is your unique perspective, not only on all the different spaces that you've been in, but also in all the different states that you've been in. So to me, you're able to see trends You're able to understand as a whole what CNAs need, and you're able to see trends, I think, in all the hierarchies of nursing. I mean, would that be a fair thing to say, that you can kind of see what really is going on across the country with CNAs?
Amongst the forums and my very large network of friends and coworkers, yes, I think that I pretty much have a pulse of what's going on and what's kind of the undercurrent of frustrations.
Ah, my goodness. All right. So tell me a little bit about if we were to build education for CNAs, if the wound care, if we said we're going to build education for CNAs, Isaac, what would you want to see us build? What do you need? What do you need from us as an industry to be successful?
The number one thing is the power and belief that we want to learn. Because when you know that somebody wants to learn, then that changes how you interact with content and material, and you match people where they are. So we know generally that CNAs are predominantly women of color. They are generally working on average 60 hours a week between one or two jobs. The general shift is between 12 and 16 hours for most. Most are living pretty close to the poverty line. And the assumption is that these women are not smart enough to engage in material. Now, I am of the camp to say, let's adjust the material to where people can understand. A good example is the PAWSIC library is very vast. It's got some really great information. If you can translate some of that information in a way that makes sense to somebody that isn't an advanced practice provider, then that really changes the system.
Oh, absolutely. Absolutely. I mean, just introducing basics of skin, even. Just basics of skin. Just starting there, I think would be incredibly helpful. And as an educator, I know that we can literally take everything we have on PAWSIC, and we could. And you're laughing because you know.
Absolutely. Yeah.
we could take every piece. I mean, I'm thinking about everything across the board. I'm thinking about stuff that I've developed. I mean, we can absolutely make it into something that would be so reasonable and dynamic for the CNAs. Because that's what we should be doing, right? We should always be teaching at the top of people's licenses, and we should always be empowering them to want to learn more, because that's what we do as educators.
Correct.
Yeah. That's our passion. So
and us as CNAs, we know where the cap of our education is. We know that we cannot assess, we cannot diagnose. There's a lot of things that we can't do, and we have been told over and over again, you can't do these things. So we are very sure of our limitations. But if we can at least go to a nurse and say, hey, so, I've been putting Miss Jones' shoes on for the last 3 days, and she's got this little spot, and it started as, a little pin, and now it's the size of a dime, and now it's red, and Miss Jones is diabetic, that's something that we need to be discussing. And it literally could be as simple as changing her shoes.
And absolutely. And it is. I mean, it quite literally is as simple as changing her shoes. I think that's the crazy thing about wound care, right? Is it is quite literally as simple as doing a bed bath. It is quite literally as simple as watching somebody move from the bed to the chair, or helping them move, watching them walk, taking off their shoes, washing their feet, looking at their hands. That is absolutely, hands down, the most important thing for us to risk mitigate and assess for things that are going wrong. And the people that do that are the CNA. And yet we haven't empowered you enough with basic information to be able to bring that observation back to where it needs to go. Yeah, absolutely. You made a comment in a meeting that really hit me. Now, I will say, I have never done long-term care. So I'm going to put that out there like as like a little like asterisk, right? Like I've done home health, I've been in the hospital, been, outpatient. But you made a comment that really hit me is, so as a CNA, you might be in Mrs. Jones' room. You might have taken off the shoe. You might have said, ooh, hey, wait a second. Oh, this can't be good. And then you might have taken that information back to maybe the lead RN or whoever is on that team. And you said that they don't hear you. They don't listen. Tell me a little bit about that, and tell me about that across the country. Tell me what your experiences are.
And I always sound like a broken record on this one. CNAs are licensed healthcare professionals. We sit for boards. We are background checked. We are CPR certified. We are fingerprinted. We have the same stringent licensure measures as if we carry an LPN or RN licensure. So a lot of the issues is that we don't get the same recognition as a licensed healthcare provider. And that really sets the tone. That's number one thing that sets the tone. There are, and I'm going to say this as a generalization, there are a lot of really excellent nurses working in long-term care. They have dedicated their lives to working in geriatric populations, and they love what they do. And then there are the outliers that are there either for convenience, whether it's, able to pick up, random shifts on gig sites, or this is where they've kind of landed in their career. And when a CNA will come to them and say, hey, Miss Jones isn't really looking right, and I'm not quite sure what's going on, but this isn't her baseline. We have a lot of nurses that will be like, it's just Miss Jones, and just go about their day. And we'll come back and we'll be like, hey, it's now 2:00 and Miss Jones really isn't looking so great. And I'm concerned. Really right. And, it'll just get dismissed again. And a lot of that is just the disregard to the CNAs. And some of that is generally burnout.
Absolutely. I mean, yeah, we can't discuss this without discussing the very real reality of burnout on all levels from all scopes of work. So absolutely. I mean, if you have 50 patients as an RN or whatever that you're in charge of, and calling docs on back and forth and all of that, and then somebody brings that somebody doesn't look great. You're on my end from an RN. I'm like, oh my gosh, this is one more thing I have to add to my list of things to do.
Yep.
And you deprioritize it in your brain because you've already had 5 other things that you have to follow up on. And so, I mean, I do get it. It's not okay, but that's what happens.
That's what happens. Yeah.
And so it's like, it's hard, I don't want to, I don't think, Isaac, you and we're not here to like demonize any profession by any stretch, because we're all really doing the best that we can and hanging on by, I think, like the tips of our fingernails most of the time. But I mean, if we could stop just and take a deep breath for just a minute, collective deep breath. And if a CNA really is coming a couple times and saying, I'm really not liking how Miss Jones's looks, we need to check this out. That really, from an RN standpoint, that has to go to the top of my list now. It does. It absolutely does. So it's just an interesting conversation for all of us to have. And we don't talk about this enough, I don't think, out in the open.
No, and I'm definitely not trying to pit RNs against CNAs. I mean, that is
right.
That's the fable of of the decade.
I know we're not trying to do that. Like, let's not do that. Yeah.
But I had mentioned to you, before we started the deep conversation is, I'm in a forum, and they said, what is the hardest part about being a CNA? And I'm reading through the comments, and I said, lack of supplies and not enough staff, and having 30 residents, which is obscene, but it happens. And 30 is, I've seen worse. I've had worse. But the number one comment was not having a nurse that is able to help.
Oh.
And it could be literally, can you get Miss Jones water while I'm giving, Mr. Smith a bath, or can you catch that call light because I've got my hands full with someone else? Like, it's literally these small little moments. And then I always, when I'm working, I always catch the nurse and I say, hey, so I'm going to give Miss Jones a bath. Do you need to do a skin assessment? Now is
Ah,
the time for you to put your eyes on this
perfect.
patient. And
Whoa.
some of them are like, I don't have time. I got to go do wound treatments. I got to go do meds. I got to, do paperwork. Miss Smith down the hall fell. Now I got to do neuro checks. And I
Mm.
understand that, but I always try to open the door. And a lot of my CNA friends also try to open the door and say, do you need to do a wound check? Do you need to do a skin assessment? Do you need to do, anything nursing related? Because now I've got Miss Jones in the perfect position.
Right now, you can do the entire head to toe check that you normally wouldn't be able to do. Oh, that is phenomenal.
Hmm.
That is phenomenal. Yeah, absolutely. And yet, the nurse can't always go. Can't It sounds like they're not always able to actually stop what they're doing and go. And
Yeah.
so again, that's the complete circle back to the basic skin and wound training for the CNAs to be able to recognize that something is wrong. We're not
Hmm.
asking for an assessment. We're just asking for recognition. Hey, this isn't
Correct.
right. Or I know that this patient has these things and this isn't right. And then
Correct.
being able to describe it or something along those lines.
Yeah. If
Yeah,
you are using the
that is
CNA as your ultimate observer, then they have
right.
to have the vocabulary to describe what they see.
Okay, can we put that we need to write that down. Like that's really important. Like the CNA is the ultimate observer and they need to be educated to be able to speak to what they're observing. Like they need to be and then they need to know how to escalate it. Oh,
Hmm.
I think we just figured out our first class together that we're going to teach. Isaac, I'm pretty certain. Like don't forget this because this needs to happen. I mean, it just does. I mean,
Yeah.
hands down, it just has to happen. And yet, and again, I think this is necessary. I think this is a necessary conversation right now.
Yeah.
We have to open up this dialogue absolutely right now. It is imperative. Wound care is over a $22 billion a year. Wounds are over $22 billion a year of a problem.
Hmm.
And we have an entire group of people that we need to teach that could theoretically identify something before it gets
Yep.
to the point of you know
Yep.
hospitalization.
I have worked with some really amazing teams. One, believe it or not, was psychiatric, geriatric, state funded health. So it was a
Oh,
facility dedicated to people over the age of 65 with psychiatric issues that were in state custody for a number of reasons.
oh,
And it was anything from maybe they have a criminal record to maybe they have bounced around different facilities and they've gotten to be too violent to be at a regular nursing home. And that particular facility was incredibly difficult for a lot of reasons because that was a very hard population. But they had a dedicated, and I hate to use the phrase, but this is what we use in the CNA vernacular, is the check and change team. And
oh,
if you were assigned on the check and change team, that is all you did. Every 2 hours, you were taking your folks to get them checked, changed, make sure that they were clean and dry, powdered, lotioned, whatever was necessary
oh.
in their care plan. Zero skin issues in that
Wow,
facility
because you
during that
literally
time.
had like an entire team that their only job was to check and change.
Yep.
Wow.
Yep.
Wow.
Yep.
And zero skin issues, you're saying? Like you
Zero
didn't
skin
have.
issues.
Wow.
Nope. And
And
if things
wow.
were starting to percolate, they were caught early. Because you
Yeah.
had a lot of eyes on that patient at any given time. And, you were working with these folks 12 hours a day. And so you're like, oh, hey, I see this spot. Maybe we need to put some lotion on it. And is it going to go away in the next couple of days? And if it doesn't, all right, now what?
Right.
Yeah.
Oh my
Zero skin
goodness.
inch. Yep. I boast about that facility all the time because they understood what it meant to keep skin integrity.
Wow. Wouldn't that be amazing if a check and change team could become standard across the country in every
Mm-hmm.
setting? Wow. Oh my
Mm-hmm.
gosh. That would be absolutely phenomenal. And maybe it's something we need to work on. I mean, maybe it's something that we really need to, how can we make that happen? I don't know, but it would be amazing if we could.
There's a lot of issues on why it's not not possible in some facilities. And a lot of that has to do with how nursing homes are managed. The Centers for Medicare and
Yeah.
Medicaid, they're a little tight with their policies.
True. Yep. 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 I guess that's true. I guess that's true.
Yeah.
Well, let's move on. Let's talk a little bit about, and because you and I had such amazing conversations. I always enjoy my time with Isaac. Every time I jump on a call with him or something, we always have great conversations. But I think let's talk a little bit. I want to talk a little bit about the patient ratios, the staffing, the responsibility, all of those types of things. Give me a little bit of insight as, again, somebody who doesn't necessarily, live in the SNF world or the long-term care world, but give me a little bit of an idea of what your day-to-day looks like with that as a CNA.
So I will preface this as I don't have a staff job. Right
that's
now,
true. Yep.
right now I do per diem shifts through some of the gig apps. So I fill staffing needs across the area that I'm at right now. And I have done that across the nation, and I've done that in what's called short-term contracts, which is 3 to 6 months, or it could go longer based on staffing needs. There are some contracts that are literally a week long, 14 days, a couple months, and it's in the hopes that a facility can onboard enough home staff to not have to use us agency folks. So a lot of the things that I see when I come into a facility, I'm seeing with brand new eyes because I haven't been there 6 months. I haven't been there a year. I haven't been there 5 years. So the issues that I'm seeing, that I'm picking up on, I'm just like, oh, wow, that's a problem. And ooh, that might need a policy, but I'm not at the point where I can say, hey, so do you guys have a policy on ABC? Because I'm seeing this as a major issue.
Oh, yeah.
Yeah.
How do you internally handle that? Like, how do you internally go, oh gosh, this is a really big problem here, but you don't have the ability to shed light on it?
Depending
that would
on
be a
what,
struggle.
depending on what it is, sometimes I do shine light on it. I definitely have gone to charge nurses and been like, hey, so let me tell you, this is a safety issue, or this could be a potential safety issue. I'm not afraid to kind of ruffle the feathers because I don't depend on that particular facility for my paycheck.
So, yeah. So actually, you do have the freedom and the ability to ruffle the feathers because you aren't there long term. And so you can bring up the problems and you can say, now I'm leaving for the next.
Yes.
Here's your major problems.
Right.
I'm out the door. I'm going to go to the next facility.
Yeah. I do. If I'm somewhere 3 to 6 months, I do ask for an exit interview, and I do say, okay, so here's the challenges that I've faced in the last 6 months. Do I always get exit interviews? No. Most of the times I don't.
Makes sense. Yeah.
But I do ask for them because it is important for somebody to be able to say, here's why I would choose not to be part of your staff.
Right.
And here's why I'm dipping out. Like, I'm done.
Like, I'm not coming back. Like, it's not happening.
No.
Hello, my name is Max Bierhup, and I'm the owner of Maximilian Creatives and the video producer helping bring Healing by Design to life. I've been in the wound care space for over 6 years, and I've seen firsthand the challenges clinicians and patients face every single day. It's a complex problem, and honestly, it's one that's still incredibly underrepresented and definitely undereducated. That's what pushed me into this space. I help healthcare and wound care brands bring what they do to life through video production, commercial photography, and even multimedia design that makes it clear, credible, and meaningful enough to create real change. I take complex care and turn it into something that people can understand, trust, and actually act on. Because better communication doesn't just grow a brand, it supports better care. I'm especially passionate about working with people who are trying to move healthcare forward and not just exist in it, make real change. And if that's you, I would love to connect. My name is Max Bierhup, and I'm the owner of Maximilian Creatives.
Well, that talks. So let's kind of roll into that whole idea of moral injury and because I think every single and we're going to talk a little bit about the nursing hierarchy as well, but the moral injury, because all of us in every single position in the medical field right now, regardless of who we are all in immense amounts of moral injury. We cannot take care of our patients the way that we were trained to or the way that we would like to on an everyday basis. I know we could talk probably for hours about how the system is not allowing us to do that. But shed a little bit of light for me on how moral injury affects you and how it affects other CNAs that you talk with.
Well, I'll go back to the previous question because that kind of leads into moral injury. So when I go into a facility on any given day in any given state, because of state mandates or lack thereof, I can have anywhere from about 15 residents to I've had up to 45.
45?
45. Yep. I literally just read somebody had 60 the other day because of call-outs.
Wow.
Yep.
That's impossible. I mean, that is actually like physically impossible. I mean, it's not
Physically
possible.
impossible.
It's physically impossible.
Right.
Yeah.
So if you can imagine that and I'll preface this with the idea of, most CNAs, again, are predominantly women and predominantly minority women. So if you could put yourself in a position of saying, I am now a mom of 60 people that I have to make sure are fed, dressed, clean, toileted, ready for dialysis, ready for doctor's appointments, dressed for Sunday church, whatever the given day is, I now have, this ratio of people. And CNAs are very common to say, these are my people. We do take ownership of the people that we're assigned to. And when you go into a facility and a CNA says, oh, these are my people, these are my 12, you know just by that statement that CNA takes their job seriously because they are going to make sure that those 12 people are clean and hydrated and fed and turned and whatever is needed within their care plan. But if they have on Monday 12 people, and on Tuesday, they now have 24 because there's been a call out. And on Friday, they now have 40 because there's been 2 call outs. The amount of care that they're able to give over the course of the week, one, they're already tired because they've worked all the way Monday through Friday, but now they have triple the amount of residents. And at that point, it literally becomes a war zone of signs of life.
Right. You're triaging as best as you can. Signs of life.
Signs of life. You are doing your check-in changes probably once a shift. And I hate to say this, but it happens. You are getting vitals if you can, or as the nurses recommend. You are doing positioning if you can. And all of this leads into the moral injury. And so what moral injury is when you are put in a situation that morally you know what the right thing to do is, but you don't have the staff, resources, or ability to act on your morals. And as CNAs, we're left out a little bit. So nursing has a code of ethics. CNAs do not have a unified code of ethics, but what we do have in our curriculum is you will always treat patients with dignity and respect, and you will always provide them with the care that is necessary for them to thrive in their environment. So if you have 12 patients, then you know that you can do Miss Jones's hair and you can make sure her dentures are extra clean, versus when you have 30, she's not going to get the same dedicated care. And that creates moral injury. And when you have a system that continually creates these little chips, it's like you have a teacup and you start chipping away at it. It can't hold water anymore. And so you have these CNAs that love what they do, they love their residents, but they literally do not have the emotional or spiritual reserves to keep going. And it is so much deeper than PTSD, and it's so much deeper than burnout, because burnout is when you're like, I've had enough of this, versus I am now injured from doing what I'm supposed to be doing. And it takes a long time to recover from.
Yeah. And you can't necessarily, you don't have the luxury to recover. You have to keep going. So you're literally, you have no cup. You've chipped away the whole cup at this point. Like there's nothing, there's no cup left.
Correct.
And we're all, all of us, docs, NPs, PAs, everybody across the board. So I think you explained that so well. We hear that word moral injury, but what does it mean? And Isaac, so I appreciate it. You did a great job explaining what that actually means and what that does to a soul. Because it it takes chunks out of your soul is what it does.
Yeah. I had the pleasure of presenting a presentation on moral injury at a CNA conference, and I struggled with, what do I name this presentation? And I sat on it and I thought about it and I said, Soul on Fire, because that is literally what I felt. Because, you can take days off and you can take a vacation and you can kind of recharge yourself, but that doesn't deal with the wound. Where PAWSIC is all about wound care prevention and education, moral injury is a wound.
Oh, well, now we just have a whole new podcast. No, you're absolutely. we just never mind. Moving on to podcast number 2.
Number 2.
Number 2. Moving on. No.
Yeah.
But that is, oh my gosh, think about that. Moral injury is a wound that festers constantly, and it is never allowed to heal. Mm-mm. It isn't. It's never. If we talk about wound care, you're perpetually locked into the inflammatory phase of moral injury.
Well, in a lot of my CNA populations, not only is it inflamed and it's infected, but we're now septic.
Mm-hmm. Right. You're septic. Yeah.
Septic.
You have moved on from the moral injury is no longer, surface. It has gone, body wide. It is now the entire body, and you are now septic, and you are in systemic inflammatory response at this point. Your blood pressure is bottomed out. Your heart rate's gone through the roof, and now you're losing your toes and your fingers. Yep. And that's where you're at.
Yep. And this is one of the multi-component issues of why CNAs are leaving the industry.
Wow, yeah, absolutely.
It's totally complicated, and there's a lot of facets to it. But if you sat down with a CNA and you ask them, "Why are you leaving? What's your exit interview?" They'd be like, "Well, I try to tell the nurses what's going on, and they don't listen. And I never have enough supplies for Miss Jones, and I just need more laundry, and I just need extra help." And it's really small things that can be changed in the system.
Yeah.
But again, there are limitations, and I understand that there's limitations, but we are losing really good CNAs because they don't know what they're feeling. A good therapist will say, tell me about what you're feeling, and maybe we can put a word to it. And so when I started talking about moral injury, people were like, oh, well, yeah, that makes a whole lot more sense, because I'm not just burned out. I'm not just like, I don't want to go to work on Monday. It hurts, and there are a lot of nurses that are doing the same thing when they're coming home from work and they're sitting in their car and they're literally in tears. And that I had those moments, during the pandemic. I would come home and I literally could not get out of my car because I'm just like this ball of ouch.
Oh, yeah. And I think we're all still, we could talk about this for hours and hours and hours. We, as a profession, the nursing profession, the whole nursing profession, from CNAs all on up. We are still in recovery mode from the pandemic. Oh, yeah. Very much so in recovery mode. And quite frankly, I'm not even sure if we're ever going to really recover to what we were prior to the pandemic at all.
No. And I, working through the pandemic, and like I said, I was in 5 different states in 2020. One of the states that I was in was New York. And I was there, I was there April to July of 2020. And I usually tell everybody what you saw in the news was true and then some. And I left New York with a lot of ouch. And it wasn't in the way that I expected. I've worked in long-term care and hospice and seen the dying process and seen the grieving process. What I saw in New York was not that. What I saw in New York was a lot more of just overwhelm and people put in situations that, had we not been in a global pandemic, they would have made different decisions.
Right. Yep. Absolutely. I was in a hospital at that time during 2020. I was inside of a hospital. So I completely 100% agree. There would have been different decisions made for certain, had we had the ability to just stop for a second and just take a deep breath and think through even our basic standards of care.
Correct.
So yes, absolutely. And so again, so we really haven't recovered. I mean, us as a profession, we haven't recovered. So we keep hearing about, the nursing shortages or the CNA shortages. And it started, I mean, it was not great prior to the pandemic, enter the pandemic, and now out the other end of it. And the moral injury, we don't even have a cup left. There's no cup.
No.
There's a giant wound.
Yeah.
It might be covered in maggots.
Oh, it's definitely, yeah, it's
maggots.
It's definitely festering. Yeah. And one of the things that I bring up all the time with CNAs is that for some reason we are seen as highly expendable. And they put us in what's called, and I hate to say this, the churn and burn cycle. If we burn, let's pretend, I'm a brand new CNA and I burn out within the first 6 months to a year, that's expected. Somebody else is going to take my place. Yep. The average turnover rate for a CNA is about 2 years.
Wow.
Yeah. And that's for a number of reasons.
Oh, absolutely. Absolutely. I'm really curious. I do not know the stats of my own profession, but I don't think it's super great either. Of my own license level, I don't think it's super great either. I think but that is, absolutely. You are expendable. Bring in the next person because that's what we're going to do. Oh my goodness. So, we have covered so many topics really, from how can we educate, how can the wound care industry really bring in, how can we bring in the CNAs, because truly you're our eyes and our ears and our hands. And so how can we educate? I think we've kind of talked about let's change some of the wording. Let's figure out what's important. Let's listen to the CNAs. What do they want to learn? And then I think understand that CNAs are like super excited and very hungry to learn and understand. So let's think about that first. And then how can we repurpose some of the education that we've already made? Because it's absolutely repurposable for our CNAs. Absolutely repurposable. And then, the question is that how can we value our CNAs? How can we step outside of ourselves and really start to look at CNAs in a different light and value what you bring to the table, for certain. Very, very, very important. And we've talked a lot about the moral injury of CNAs and really the moral injury of the medical industry, as a whole. And I really love how you described that. That was phenomenal. I know we wanted to talk a little bit about, the toxic cultures of the nursing hierarchy. And I think we've kind of covered that a little bit, is that, I think ultimately, boy, wouldn't it be great if we could just all work together?
Oh, yeah. Yeah.
We just all work together.
Yeah. Well, as a nurse, the saying that, nurses like to eat their young. Yeah. Yeah. They particularly enjoy snacking on CNAs.
Yes. You guys, for some weird reason, you have like frosting on top of you. I don't understand. You have sprinkles and stuff. It's terrible. You're extra tasty, apparently.
Yeah. Yeah. And, again, I always go back to it's the vocabulary, because I am versed enough to know when I'm getting a particularly snarky nurse what it is, which is lateral violence. And I can say, hey, so that's not okay. But the rest of my CNA network may not be able to say, oh, that's a microaggression, that's a macroaggression, that's lateral violence. What is, I just know that this nurse is picking on me and she just doesn't like me and she never listens to what I have to say. It's a little deeper than that.
Yeah, no, absolutely. And somebody made a comment to me as a whole, and I think this resonated with me, and we can talk about this just for a little bit, was nursing as a whole has been a marginalized profession as a whole. And so we respond appropriately.
We do. And, the latest political news, with nursing being declassified as a professional, really set the stage for some folks to say, okay, well, now I'm going to change my behavior.
Right.
And now I'm going to change how I move forward. And, maybe that graduate degree where I was going to become a nurse practitioner, I'm not going to do anymore.
Yeah, I'll stay here. I'll stay where I'm at. Right. Absolutely. It helped me when somebody described to me that, we've always been kind of an oppressed, really an oppressed profession all the way through. At first I was like, nah, I didn't. And then the more I thought about them, I'm like, oh my goodness, absolutely. And that is kind of why I say we as a whole tend to eat our young or climb on top of each other, is because I think of the oppression that we've had as a collective profession. It's just, I never really understood that until I really sat back and spent some time thinking about it. And it is absolutely true.
Well, there's also the expectation, and as CNAs, we are constantly hit, bit, scratched, spat at, had things thrown at. I've had glasses broken. And this is not just in behavioral health, this is working in long-term care. When you go home and like my partner is super supportive and I'll be like, oh man, I got scratched by Miss Jones again. And she's like, oh, they didn't trim her nails. She understands. But if I'm sitting in a mixed population and I'm like, oh man, I got beat up again by my little Grammys and Pop-Pops. I've had some people say, well, you chose that life.
Oh.
And I always look at them going, yes, I chose to be a healthcare provider, but I did not choose to be abused at my workplace.
Right.
You know.
And that seems to be escalating more and more. I can forgive all of my sundowning, beautiful sundowning. I can totally forgive them. I
can. Yeah, I do.
Can totally.
Yeah.
We can definitely forgive them. But I mean, there is a huge increase in violence and all. And I think in all settings. And so not only do we have our moral injury, right, but now we're being physically, injured as well. So, oh my goodness. So to wrap this up, I think you and I could probably talk for the next 3 hours about all of these things. To wrap this up, I think the takeaways here are in wound care, CNAs are truly vitally important for us to move forward as a profession. I just was at a conference and we really talked about the patient voice. We talked about the patient goals. We talked about paying attention to the patient. And we can't do that without incorporating the entire nursing care team, which includes the CNAs. And so therefore then we need to educate the CNAs. And Isaac, I have to say, I am so excited to have you on PAWSIC because I really see you as a pioneer, as a CNA pioneer in the wound care industry, to bring your knowledge about your profession, bring it to us so we can all work together to make the change that's needed.
I appreciate that.
Yeah. So we are so excited at PAWSIC to have you. I'm going to wrap it up. Isaac, this has been a wonderful conversation. I have learned so much. I have so much enjoyed having you on Healing by Design, our PAWSIC podcast. Who knows, we might speak again. All of our listeners out there, I hope you had a wonderful time listening to Isaac and I today, and I hope you have a great rest of your day. Thank you so much for joining us. And that's a wrap on today's episode. Thank you so much for spending time with us. These conversations are why we do this, and we don't take it lightly that you chose to listen to us today. Before we head out, just a reminder, everything you heard today is meant to educate, not to replace the advice of your own healthcare provider. Please don't make medical decisions based on what you hear on this show. Your provider is the right person for that. Our guests share their own opinions and experiences, not the official positions of PAWSIC or anyone who supports this show. If you're dealing with a wound care emergency, please get to someone who can help you right away. And if today's episode was useful, subscribe and share it with someone in your corner of wound care. It helps us reach the people who need it the most.